Dear panelists, ladies and gentlemen, my PhD takes a translational approach to the prevention of diabetes after acute pancreatitis and in prediabetic individuals. I'm Olga Zahariev. I'm a UK-trained dietitian who is currently working at the Pancreatic Division at Semmelweis University. My vision is a world where preventable diabetes is prevented, and my mission is to shift healthcare policy towards prevention and to educate patients. I will use various methodologies to explore my topic of interest. The first project is identifying patients at risk of developing diabetes after acute pancreatitis. The second project is aiming to investigate the effectiveness of various diet and exercise interventions on preventing or delaying diabetes. And the third project is actually a clinical trial which studies the effect of dietary fat reduction on the recurrence of acute pancreatitis and endocrine insufficiency. The first project is identifying patients at risk of developing diabetes after acute pancreatitis. Diabetes mellitus is a huge economic and health burden on society. It is the 9th leading cause of death globally, and it is estimated to cost $1.3 trillion in 2015, which is projected to increase by 61% by the year 2030. Moreover, around a quarter of the population who had acute pancreatitis go on to develop diabetes mellitus within the first 5 years. At the moment, there is a gap in knowledge regarding the diabetes mellitus formation after acute pancreatitis and patient management. Therefore, as a first step, my project aims to identify patients at risk of developing diabetes mellitus after acute pancreatitis. The question is, what are the risk factors for developing diabetes after acute pancreatitis? The population is patients who had acute pancreatitis but had no diabetes mellitus at the point of discharge. We will look at various biomarkers such as etiology, complications, and severity of the disease. We'll also assess body composition. The outcome we are looking at is new onset diabetes and glucose dysregulation. We hypothesize that diabetes mellitus develops significantly more frequently in acute pancreatitis that was severe, necrotic, or caused by hypertriglyceridemia. The clinical implication of my first study is that when we know who is at risk of developing diabetes, we can monitor them appropriately and therefore use early intervention strategies and hopefully prevent diabetes mellitus formation. But in the worst case scenario, we can at least catch disease early on. The protocol for the meta-analysis has been submitted on the Prospero registration, and we carried out the systematic search in October on 3 databases with the search that you can see on the slide. We have identified nearly 12,600 records, and the selection has been started as per PRISMA protocol. Now, having identified these patients, we need to have an idea what kind of early intervention strategies we need to use. Therefore, the second project aims to answer this question. We have established that diabetes has a huge health and economic burden. Moreover, its prevalence is still increasing. However, its development takes years, and it is preceded by prediabetes. Lifestyle interventions have been shown to reverse prediabetes. At the moment, there is a lack of guidance on the most effective lifestyle intervention for delaying or preventing diabetes. Therefore, the aim of the second project is to identify the most effective exercise or dietary intervention to prevent or delay diabetes mellitus. The question is, what is the most effective lifestyle intervention? And the population we are studying is prediabetic or insulin-resistant adult. We will examine various diet and exercise interventions, and the outcome that we are looking at is new onset diabetes. We hypothesize that there is a difference between the various diet and exercise interventions on preventing diabetes. The clinical implication of this study would be that it would provide an evidence-based intervention for preventing or delaying diabetes. This is important because nowadays people feel that they become experts on nutrition just after having read a couple of articles online. However, clinical practice shows that using evidence-based guidelines is the safest and most effective treatment for patients. The preliminary search has identified several records. However, the registration has not yet been started for this project. I am lucky enough that I can take part in a third project. This one is a clinical trial which is investigating the effectiveness of a specific dietary intervention in acute pancreatitis population, namely the reduction of fat. Up to 35% of the patients who had acute pancreatitis go on to develop recurrent pancreatitis or chronic pancreatitis. However, at the moment there is no treatment to prevent recurrences aside from abstinence from alcohol in alcoholic acute pancreatitis and cholecystectomy biliary acute pancreatitis. Nonetheless, low-fat diet is often recommended to patients without actual evidence base behind it. Therefore, the aim of this third project would be to assess whether dietary fat reduction could affect the recurrence of acute pancreatitis. This study actually, the protocol has been published in Pancreatology already, and we are looking to have two arms. We aim to enroll 200 patients in each of them. The first group would be instructed to consume 15% of their total calories from fat, and the other group would be instructed to consume 30% of their total calories from fat. The intervention, the patients would receive 5 sessions of dietary counseling, and they would be followed up over a period of 2 years. We are including patients who had at least 2 acute pancreatitis episodes, and they have to have the last episode to be idiopathic. And the primary outcomes that we are looking at is acute pancreatitis recurrence, all-cause mortality. We are also investigating glucose control and the serum lipid as well. We hypothesize that the low-fat diet reduces acute pancreatitis recurrence and endocrine insufficiency in idiopathic acute pancreatitis. If this proves to be true, dietary fat reduction will be the only evidence-based preventive intervention for idiopathic acute pancreatitis recurrence. As a summary, my PhD project will achieve 3 things. The first project would identify people at risk of diabetes mellitus after acute pancreatitis. Secondly, I will be able to enhance the understanding of the efficacy of various lifestyle interventions on preventing diabetes formation and to determine if dietary fat content affects acute pancreatitis recurrence and progression to chronic pancreatitis, exocrine and endocrine insufficiency. I would like to close my presentation with a quote from Thomas Edison, which links back to my vision. The doctor of the future will interest his patients in the care of the human frame, diet, and in the cause and prevention of disease. Thank you for your attention. Please feel free to ask any questions.
I'm just curious about your experience regarding the quality of the papers for your first project. As you kind of experience in gastroenterology that follow-up studies there are not really follow-up studies, good follow-up studies. And regarding your first question, to really answer what is the prognostic, what are the prognostic factors for diabetes, you need the proper follow-up and the data collection to really know actually the prevalence of diabetes, and after that you can of course check without or with less bias. But what is your experience, what is your opinion on this situation, this question?
So you might have noticed that the selection is also going slow because it's quite difficult to identify the papers without missing any that are relevant. Having looked at a couple of them, it's going to be a challenging problem. Some of them start and have the follow-up at 1 month, which might not be ideal for us. We would be looking at a couple of more months, probably would be better. But they included everyone and they put them together. We will probably use the study because it includes several patients and some of them are followed up for 7 years, but we just don't know the exact. Sometimes it's a big limitation. Thank you for highlighting that.
I would like to congratulate because these topics are really interesting. And I have one question regarding the third project and in connection with the fat intake. So, do you plan to set the percentage of different kind of fatty acids as well? So like saturated, unsaturated, or the MCT fatty acids? So do you have any plan for that?
It hasn't yet been discussed. There are actually a couple of things we still need to decide with the dietary intervention. We still haven't established whether they're going to have some hypocaloric if they are obese. There is lots to discuss. I don't think we'll go into the specifics of the fat types because it would be very difficult for patients to understand. Even just the difference from to go down to 30% or to go to 15% is going to be a big difference for them because most Hungarians consume more than 30% fat. So that will be already a big change.
Yes, thank you. And just another question related to that you just mentioned that. Would you like to so like teach people then to be able to reduce their fat intake. So like regularly you will meet with them, like a dietitian?
Yes, yes. So we would see them at the start of the project at 3 months, 6 months, and 12 months, 18 months as well.
Yes.
We were planning to see them only 2 times initially, but when the patients were invited to review the protocol, they said they would prefer to have more frequent meetings with the dietitian. So we increased from 2 to 5 sessions.
And will you collect data about their nutritional habits during this?
Yes. So at each of these time points, we will collect data, and the 24 mark first of the 2-year one, we will only collect the data, but give no more counseling sessions. So that's how it's built up.
Thank you.
Thank you.